I just technical IT, wonderful. So sorry, like I was saying, my name is Michelle Joblin. I'm one of the therapy area specialists for Organon. Thanks very much for joining the Fitter Forum today. I appreciate you've all got busy schedules, so it's lovely to see so many people on. By way of introduction, you may already know Sarah, but Sarah is one of our faculty registered nurse trainers, but some of you may already know Sarah from some of the training she's done in Sheffield. Just for a little bit of background, Sarah's subcontracted to Organon via a company called Bionicle, and it's basically part of our risk minimisation programme for Nexplanon. So what I'm going to do is I'm going to show the insertion and removal videos first, and then Sarah's going to go into her presentation from there. Any problems at all, if you can pop it in the chat or on mute, but I'm going to fire away and start the videos now. Any problems, like I say, give me a shout. Oh, hang on, I need to unshare. 2 seconds, I just need to unshare. Just bear with me. Sound, share.
Insertion of the implant should always be performed by a healthcare professional trained in the insertion procedure. Have the patient lie on her back on the examination table with her non-dominant arm flexed at the elbow and externally rotated so that her hand is underneath her head or as close to it as possible. Identify the insertion site, which is at the inner side of the non-dominant upper arm overlying the triceps muscle, about 8 to 10 centimeters from the medial epicondyle of the humerus, and 3 to 5 centimeters posterior to the groove or sulcus between the biceps and triceps muscle. This location is intended to avoid the large blood vessels and nerves that lie within and surrounding the sulcus. If it is not possible to insert the implant in this location, for example in women with thin arms, it should be inserted as far posterior from the sulcus as possible. Make 2 guide marks on the skin. First, mark the spot where the implant will be inserted. Second, mark the spot 5 centimeters proximally towards the shoulder from the first mark. The second mark will later serve as a direction guide during insertion. After marking the arm, confirm the site is in the correct location on the inner side of the arm, ensuring 3 to 5 centimeters posterior to the sulcus. Clean the skin from the insertion site to the guiding mark with an antiseptic solution. Anesthetize the insertion area, for example, by injecting 1 to 2 mL of 1% lignocaine under the skin along the planned insertion tunnel. Hold the applicator just above the needle at the textured surface area. Remove the transparent protection cap by sliding it horizontally in the direction of the arrow away from the needle. You should visualize the white implant by looking into the tip of the needle. Be sure to avoid touching the purple slider until you have fully inserted the needle subdermally, as this can retract the needle and prematurely release the implant. To help ensure the implant is inserted just under the skin, you should position yourself to see clearly the insertion site and advancement of the needle just under the skin by viewing the applicator from the side during the procedure. With your free hand, stretch the skin around the insertion site towards the elbow as shown. Puncture the skin with the tip of the needle slightly angled less than 30 degrees. Insert the needle until the bevel is just under the skin and no further. If you cannot visualize the bevel after skin puncture, withdraw the needle until the bevel is just under the skin. Lower the applicator to a nearly horizontal position. Lift the skin with the needle, also called tenting, as you advance, ensuring the needle is advanced to its full length. Ensuring the applicator and needle remain in the same position, Unlock the purple slider by pushing it slightly down, and then continue to move the slider fully back until it stops. The implant is now in its final subdermal position, and the needle is locked inside the body of the applicator. The applicator can now be removed. Check the applicator to see that the needle is fully retracted into the body of the applicator, and only the purple tip of the obturator should be visible. Apply an adhesive plaster over the insertion site. This can then be removed 3 to 5 days later. You may also apply a pressure bandage, and this can be removed after 24 hours. Always verify the presence of the implant in the patient's arm at the end of the procedure by palpation. By palpating both ends of the implant, you should be able to confirm the presence of the 4 centimeter rod under the skin. The patient should palpate the implant and be reminded to continue to check for its presence. Until you have verified the presence of the implant, the patient must use a non-hormonal contraceptive method. Complete the user card and give it to the patient to keep, and complete the adhesive label, which can be inserted into the patient's medical records.
We're going to go on to the removal video now as well, and then Sarah's going to go on with her presentation.
Thanks, Michelle.
Removal of the implant should always be performed by a healthcare professional trained in removal techniques. Before initiating the removal process, verify the exact location of the implant in the arm by palpation. Have the patient lie on her back on the table. The arm should be positioned with the elbow flexed, with the hand under the patient's head or as close to it as possible. Locate the implant by palpation. Push down the end of the implant closest to the shoulder to stabilize it. A bulge should appear, indicating the tip of the implant that is closest to the elbow. If the tip does not pop up, removal of the implant may be more challenging, and it may be necessary to have the implant removed by a clinician experienced in removing deeper implants. Mark the distal end of the implant, the end closest to the elbow. A surgical marker may be used. Clean the site where the incision will be made by applying an antiseptic. Anesthetize the site, for example, with 0.5 to 1 mL 1% lignocaine, where the incision will be made. Be sure to inject the local anesthetic under the implant to keep the implant close to the skin surface. Injection of local anesthetic over the implant may make the removal more difficult. Push down the proximal end of the implant to stabilize it throughout the procedure. Starting over the tip of the implant closest to the elbow, make a longitudinal incision of 2 mm towards the elbow. Take care not to cut the tip of the implant. The tip of the implant should pop out of the incision. The implant can now be removed. If it does not pop out, gently push the implant towards the incision until the tip is visible. If needed, gently remove adherent tissue from the tip of the implant using blunt dissection. Grasp the implant with forceps and, if possible, remove the implant. If the implant cannot be grasped, stop the procedure and refer the patient to a healthcare professional experienced with complex removals and report it as an adverse event to the manufacturer. Be sure to remove the entire implant and confirm that the entire 4 cm implant has been removed by measuring its length. If a partial implant less than 4 cm is removed, the remaining piece should also be removed. After removing the implant, close the wound with a sterile adhesive bandage. This can be removed in 3 to 5 days. You may also apply a pressure bandage. This can be removed after 24 hours.
Thanks, Michelle.
No problem. So I've stopped
Right.
sharing. I'm going to hand over to Sarah now.
I'll see if I can share my screen. Just bear with me. Can you see that, Michelle?
No, not yet.
Not yet. What have I done? Oh,
So share and then
Uh,
basic screen, yeah?
share
That's it. Yep.
from the beginning. Oh,
Yeah.
there we go. Can you see that now?
Super, yeah.
Thanks for doing the videos, Michelle. It does make my life a little bit easier because I'm not great with technology. So welcome everyone to this afternoon's Fitter Forum. I'm Sarah Pearson. Michelle's already introduced me. And really the session this afternoon is just very relaxed session, just really to update you all within the world of Nexplanon. So Michelle's already explained that we work for a company called Bionicle. We're a team of trainers that cover the whole of the UK, offering training for anybody that's brand new to implants and also support sessions for people that have maybe lost their confidence or need to convert from a local lock to a faculty lock. So the agenda, an implant update, that's the whole purpose of this afternoon's session. The videos, Michelle's already kindly shown those. Good practice points, training and support, and questions and discussion time. So that actually is at the end, but I think, to be honest, it's probably best if you've got any questions just to ask them as and when they pop up within the presentation. So feel free to pop it into the chat or just unmute and ask as we go along. It's not a problem. So I think the big thing that we really talk about a lot in relation to Nexplanon is the insertion site. So where do we actually fit the implant? Lots of discussions over the last couple of years as to where we should be fitting it. And there's always been two different schools of thought in relation to this particular site. Is it, bicep? Is it tricep? Where's the groove? Is it below the groove? And I think this diagram here that you can see on the top of the screen highlights exactly where we need to be fitting the implant. It's always been 8 to 10 centimetres from the medial epicondyle as Nexplanon. Implanon, its predecessor, was 4 to 6, and now and again we still see implants are fitted a little bit closer to the elbow than we would like, maybe because of the original guidance, which was 4 to 6. But for more than 10 years now, the guidance has been 8 to 10 from the medial epicondyle, avoiding the groove. Now, I think the problem is the groove is a little bit of a mystical creature. People don't know where the groove is. Where do we find it? What does it look like? So the guidance that was relaunched and the updates from 2020 recommended an additional measurement, which was 3 to 5 centimetres posterior to the groove, which for a lot of people didn't really make any sense, because if you can't find the groove in the first place, how do we do that measurement? So as a training team, we've decided, and probably, whoever has trained you previously has maybe recommended this particular way of doing it. Ask your patient to make a fist, ask them to look for their muscles, and when you push against their fist, and sometimes doing that just then identifies where their groove is, just highlights that little bit of indentation where the bicipital groove is. Isn't always possible to do, even with that particular technique. So what we will say is, in the majority of women, if you identify where the medial epicondyle is, and you place your ruler or your hand horizontally from the medial epicondyle up towards the axilla horizontally, you will, in the majority of women, completely bypass the groove. There's an exception to this, and that's in some of the ladies that are more petite. So if they're very small and have a smaller arm, what you might find is actually they haven't got much gap between their groove and their medial epicondyle, so the differentiation it's just not there. So I think you've got to just be mindful of your very small ladies. Just careful that if you've got somebody that's very petite, take your time to measure it, try and look for the groove, but if not, just be very mindful that you don't want to be too close to that part of the arm. We all know where the bicep is located, there or thereabouts, so it's common sense. And I think sometimes having guidance and having measurements does sometimes just make us panic and think we've got to rigidly stick to those guidance. And actually, in a lot of women, it's not applicable. Sometimes you'll see people, if you fitted it at 10, it would be right up in their axilla. Equally, if you fitted it at 6, that's probably about mid-third of the arm. So just look at the arm, scrap the measurements if you're panicking about them, look at the arm and just look at mid-third and avoid the bicep. And for the majority, that will be absolutely fine. What we have found since the videos have been sort of communicated and the guidance has been changed is a little bit of too much posterior fitting, so implants that are fitted quite far around the back of the arm. And I think one of the reasons for this is that we've gone to this particular position, which is called the model pose, where we ask our women, you saw it in the video, where the hand is behind the back of the head. The reason for that is that relaxes the ulnar nerve, and it just means that you're in a nice, safe environment for fitting. However, because we've done this, it's almost encouraging people to fit a bit further around, and we think that's what's happening. So people are getting a little bit confused and thinking, because we're doing this, we have to fit around here. And I think something else that we're seeing, and in a training session yesterday, it was very evident, people are measuring 8 to 10, and then from the 8 to 10, measuring 3 to 5. So rather than identifying the sulcus, they're identifying the medial epicondyle line and measuring from there. And consequently, that is meaning that we've got some very posterior fits. It will work wherever it is sited. But what you have to remember as a fitter is, if you're going to be fitting it, you may be that remover, and you need to just make sure it's an easy, straightforward removal when it comes to it in 3 years. So just a top tip from us as a training team: when you are fitting, always mark the arm. Make sure you've got a dot where the implant will go and a dot 4 centimetres further along, so you know exactly where it will be. Step back and double check it's mid-third. After you've done that, get your patient to put their arm back down by their side. And if at that point you can see their dots, the dots from the side of the arm, you know then you've gone too posterior. So just go back in and have a little remeasurement just to double check. So again, this is just reiterating the importance of subdermal placement. If the implant is inserted deeply, neural or vascular damage may occur. So it's just about making sure you take your time, you have your own techniques for doing it, make sure it's that 30-degree angle. Don't rush. I think we all have different slots within our clinics as to whether it's a 20-minute slot, 30-minute slot, but ultimately what we need to be doing is taking the time to measure the arm, just do your dots, and if you're not sure, just double check and re-site if there's any problems there. So position, so I've already mentioned the model position, which this is how it looks. Not always easy for women to adopt this particular position. Sometimes they have a particular physical condition that means that they can't do it, so it's uncomfortable. And also some rooms just logistically aren't set up to adopt that position. Some clinical rooms have the couch right against the bed, and next to that other side of the bed there's maybe a desk or a bookcase, and it's quite a tight fit. So actually doing this is sometimes quite impossible. So I even mentioned it on the video, you know, that's the ideal position. Even if you can't get them to adopt that position, even if they're just a little bit more like this rather than like that, just so it relaxes the ulnar nerve. And I think it is just about, you know, using what you've got within your clinical environment. If you can't encourage your patients to do it for whatever reason, just common sense, take your time and try where possible. Even just half of the model pose will be sufficient to relax that ulnar nerve. Technique, so for an insertion, we would say green needle to make the track. Maximum local anaesthetic would be 2 mils. I dropped the 2 because most vials tend to have 2, but in most cases I only use about 1 mil. What our concern is with local anaesthetic is too much can displace the implant. It can make the area very swollen very quickly, and we actually might end up fitting the implant somewhere where it shouldn't be, and it just confuses and maybe displaces the implant to the point where it's gone too deep, or it's gone more towards the bicep, which is not what we want. So, you know, really, you know, green needle all the way along to make your track. I know some areas don't make the track, and again, that's absolutely fine. And this is just guidance from the manufacturer and the faculty as to how we would be doing it. But at the end of the day, if a woman doesn't experience discomfort when you've only put the local in at the sort of the entry point, that's not the problem. You know, I think you all know your audience, and you all know women that might need more local or might be quite happy just having that little minimal amount just at the very entry point. For your removal, again, 0.5 mil to 1 mil, just under the tip with an orange needle. Once you've identified that the anaesthetic has worked, we're quite cruel as a team. We don't actually check the anaesthetics worked. We give it 2 minutes, and then we just say, right, that's it, we're going to go for it. Because in our experience, you've probably all completely agree, if you test a woman and say, can you still feel it? The likelihood is they'll say, yes, I can. And their expectation will be, I want some more local anaesthetic, which is not what we want to do. And it just delays the procedure, which in actual fact, you know, it should be very quick. It shouldn't be too, you know, complicated and made into a really big clinical procedure. And I think, you know, you've probably all seen men who have Solidex, which is a similar applicator, similar device, and they don't have any local anaesthetic for that. So we're being very kind, actually giving them something. So 0.5 mil for your removal. We don't use forceps now for the removal technique. We just use the pop-out technique, where you're using your nice pointy blade to isolate the implant, pop it out, and then just encourage it out with the tip of the blade. Then it's definitely not too invasive, and it's just nice and simple, and it doesn't result in lots of unnecessary scarring, unnecessary wounds actually that can be a little bit too big, and which is obviously what we want to avoid. Anaesthetic, 1% lidocaine is our first choice for the procedures. We do know that in some areas practitioners prefer to use it with the adrenaline in as well. Absolutely fine to do this. The adrenaline then creates more of a bloodless field, which for some people just makes the removals in particular a little bit more easy and straightforward. All I can say really is about the xylocaine is that actually it's not as cost effective, and once you've opened that vial, generally the vials I see, once they're opened, you only get 3 days to use it. So often there's quite a lot of waste associated with the xylocaine, because if you're not doing lots of procedures in that day or the day after, the potential is you're going to have to discard that, which is such a shame. During the pandemic, we were asked quite a lot of questions about alternatives to local. Can we use the freeze spray? Can we use the topical anaesthetics? And the answer is that's absolutely fine to do so. The freeze spray in particular, we do know people are using it, but once it's sprayed, it only lasts for 45 seconds. So you've got to be very quick at doing your removal or doing your insertion. And what we don't want people doing is rushing, because that's when we find that people get it wrong, or we have a deep fit or a failed removal if people feel they've got to rush. So I think it's a bit of a big ask in 45 seconds to complete the procedure, but we do know it happens in some areas, and I think some people just think it just means your patient isn't in the room quite as long. But in all honesty, I only give the normal lidocaine 2 minutes to work. So really there's not a lot of difference between 45 seconds and 2 minutes. And what we do know with the lidocaine or the xylocaine is it continues to work well after. So it is the one that we would prefer to use. Some patients request it because they have needle phobia, and they would rather have less invasiveness and would rather just go straight for the implant without having the local administered via a needle. So it's entirely up to the patient. So it is there, but it's just about making sure you know you've got to act very quickly. Replacement. So a woman can have as many implants as she requires throughout her reproductive years, up to the age of 55. So this is something that we don't need to have a gap, and I think a lot of women will access and say, I need to come off contraception, I need to give my body a rest, and ultimately that happens and then they get pregnant, and that isn't really what they wanted. So I think it's important to remind women that being on a LARC, the purpose of this method is it's long acting, it can stay in situ for many, many years. We know it's a 3-year method, but it just needs to be replaced every 3 years. And just on the fact it's a 3-year method, in the lockdown period, it was extended to 4 years in the use of Nexplanon, because there's a lot of evidence to suggest it does keep working beyond 3 years. And, we didn't want to panic women who weren't able to access LARC clinics during the lockdown. So lots of women either kept it in and relied on just that method, or were encouraged to bridge as well with a POP. Shortly after that, when everything started to sort of whip back up again within services, it was very much communicated that it is a 3-year method. The license is 3 years, so where possible, we need to be replacing it or removing it within 3 years. We still have to worry that at 3 years, it may suddenly deplete and not be as effective. We've probably all seen women who we know have had implants in for many years, beyond 3 years, and it's been very effective. But because we don't have that much evidence still, we don't collect that much data in regards to this, we still have to work to the license, which is 3 years. We used to say with replacements, after 2 in a consecutive arm, we would swap arms, and more recently that's something that's become evident that a lot of women didn't like. And I think even as practitioners, it's not great, because it's almost like you're having to reposition yourself, reposition the patient, and it makes it more of a double procedure. So the evidence now is saying actually you can go back in the same hole, as long as obviously the implant's within the parameters of where it should be, within line with our guidance. Back in the same hole, but when you go back in, just angle it off ever so slightly, so you're creating a new pathway. Because if you keep going back in the same place, the same track, the buildup of scar tissue could become problematic. It's not going to stop the implant from working, it won't affect its efficacy, but it just might mean that when it comes to the removal in 3 years, it might be quite tricky because of that buildup of scar tissue. So just bear that in mind with your replacements. Something that we've discussed quite a lot in the team is when you do replace, do we need to put more local back in? So I was always a firm believer that, well, yes, because you're putting a new device in, a slightly different track, so we need to obviously minimise any discomfort. But actually now a lot of the research is saying once you've removed it and you've already got them, anaesthetised, but they're very numb from the removal, you don't actually have to put any more local back in that track for the replacement. So that's something that I'm doing now. I think a lot of the team are doing that as well. And again, I think it's very much dependent on your audience and knowing your patients, and some that are very anxious, you might just think, you know what, I need to just give them a little bit of extra. But the ones that I've been doing recently, there's not much discomfort. That, I think once they're numb from the removal, it tends to be quite successful by not putting any more local in. And the other thing about that is it just means, again, we're not creating more swelling, because if you've removed it and you're already in there and it's, a little bit tender and there's maybe a little bit of swelling already, the last thing we want to do is put more local in that might then displace that new implant that's going in. So it's just something to think about, but just bear that in mind. Bent and broken implants, hopefully we don't see too many that are completely broken. The purpose of the device, the nature of the device is it's meant to be bendy, then it doesn't snap. So we do see some that are very bendy. I think broken implants do occur. I've seen a couple. And we used to say, don't worry if they're broken, let them stay in situ, they'll still work very effectively, and just deal with that broken implant at the point when they return for their removal. However, now it's being communicated that if an implant is broken completely in 2 or maybe 3 bits, the potential is it will start to migrate and move quite significantly. So if we identify a broken implant, it's best to remove it there and then, rather than wait for the 3 years, because in 3 years you might have one end up near the proximal end, one near the distal, and you might not be able to find the bits. So I think it's just making it easy for yourself, because if you leave an implant in situ, even if you've only left a centimetre in, potentially there's enough hormone release there to prevent ovulation and fertility. So I think we need to just remove it there and then, because what we don't want is to then have to refer on to an expert remover. And you're probably all aware with expert removal, it isn't always on our doorstep. Patients sometimes have to wait quite a few months to be seen by that expert who can do the scanning and more invasive techniques to do the removal. Management of bleeding. I think this is one of the big things that we talk about in all areas of contraception. We know that this particular method does have the propensity to bring about some unpredictable bleeding, but so do other methods as well. And I think that's the problem. We get a lot of bad press with this method, but actually if there's progestogen related to a method, for some women, it just does cause havoc with their bleeding pattern. So as part of your counselling, make sure they're aware of the potential bleeding problems. And I think it's also looking at, if somebody doesn't bleed on this method, if they're amenorrheic, will that be a problem? Because I do remove implants from women who don't have a bleed on this device. And it's such a shame that they don't like it. They don't like not bleeding. They don't have faith in the method. So I think have that discussion and make sure if they're going to be amenorrheic on this method, is it the right method for them? But we don't know. Yeah.
We just have a question.
Yeah,
do you want me to keep them to the end, or do you want me
No, it's fine. Go
so
for
we
it now,
have
Michelle.
a question here. So is it okay to put local anaesthetic under the entire implant for replacement in an anxious patient, rather than just putting the local in after removal?
My concern would be if you put it all in one go, it might displace that implant and make it difficult to remove. That would be my only concern there. If you're overloading that whole area, and I've seen that done before, where people will put maybe a mil of local all the way along the track to do the removal, and then know there's going to be the reinsertion there as well. But it's just, if you think it's nice and easy to palpate, absolutely fine. But my concern might be that it just might go the wrong way and push that implant a bit further down. But if you felt that was going to be something you needed to do with your patient, there's not a problem with that. Just be mindful that it might go the other way.
Thank you.
So management of bleeding, so double check that they know what they're signing up for. They know that once it's in, it's ideally 3 months of perseverance, and even better if you can get them to 6 months of perseverance. That's the ideal. But we do know that some women, the minute their bleeding becomes unpredictable, they can't tolerate it and they come back quite quickly. So we need to look up, is there something else going on? So, is it a pregnancy that we've missed? Are they on new medication perhaps that's an enzyme inducer that we can't see? Sometimes when they're in general practice, obviously the medication's listed, but a lot of women now are getting things off the internet, over the counter. Potentially they're enzyme inducers that will stop contraception, and the knock-on of that will be they might have some unpredictable bleeding. So double check all the medication, double check the sexual health history, anything else going on, do all of those investigations first. If after that it comes back as, yep, it's the implant, this is what's causing the problem, you can introduce a 3-month supply of COC, completely off license. However, a lot of women are on a LARC because they can't tolerate estrogen methods. So if that's the situation, we're a little bit stuck. So the next step would really be to try a POP. It's not as well researched and promoted, but I think anecdotally you see that often just by doing that, it's giving that patient a little bit of hope. Within that 3 months of trying that, it might just get them to the point where their implant was going to start behaving itself anyway, and then they're quite happy to continue. It's all off license, and I think it's very much trial and error. But if somebody will just take that on board for 3 months to see what happens, then it's certainly worth doing. Complex implants, hopefully we don't see too many of these, but I think there are still a few people out there who unfortunately have to refer on because implants are non-palpable, or they just don't feel confident to sort of go a little bit deeper because the implants may be deeper at one end. All areas are very different as to how to handle this. So I think the best port of call really would be to speak to your sexual health service. They normally have the pathway, they know what the process is for the expert removals. And I think I've already mentioned it isn't always easy. Sometimes there is quite a significant waiting list, and sometimes a significant travel because that particular expert isn't always close by. Sometimes patients have to wait for them to be in the area. Alternatively, the patient has to travel to them. So I think if we can just try and get better at making sure implants are fitted well, and I'm not saying anybody in here isn't doing that, but even if you identify one that you think, actually, I'm not happy with that, you haven't fitted it, but when you're seeing somebody else for another reason and you notice their implant's not quite right, and you think it might be on its journey to becoming deep, there's no harm in removing it there and then to prevent that future deep insertion or migration. Training. So as part of the training team, we provide training for anybody that is brand new to implants, anybody that's maybe had a period of time of not doing it. And I know in lockdown, lots of practitioners have been in touch saying, you know, they haven't done some for a year, 18 months. So they just want a little bit of a confidence boost. And I think also since the guidance in relation to position has been updated and communicated, and I think because of lockdown it was communicated and then everybody stopped fitting, so I think there's been a bit of miscommunication. So if anybody needs a confidence boost or they're just not quite sure with the techniques, we're more than happy as a training team to come in and do any support sessions. So practice points, so identify position and marking of arm. I can see from some of the names that are on the call today, you're all experienced and have probably been fitting implants for many, many years. And myself, I'm very guilty of this. I think I know where I'm fitting the implant. Why should I mark the arm? Why is it such an essential thing to do when I've fitted implants for years? But I think it's just now and again good to just remind yourself and just double check that your technique and your practice is where it should be. So mark the arm, so you do your dot where you're going to fit it. 4 centimeters further along to that, that's the dot where it will finish. Then you can step back and actually look and make sure it is central to the arm. Something to bear in mind when you do fit an implant, if you fit it at 7, for example, it actually shoots forward ever so slightly. So if you're fitting it at 7, when you go back into palpate, it's actually moved a little bit further along. So it's almost like you fitted it at 8. So bear that in mind when you're fitting it. The applicator pushes it a little bit forward. So just consider that when you're fitting it. So mark the arm, take your time to look where it is. And, you know, believe it or not, we do still see implants that are fitted in the forearm, around the back of the arm. And I think, you know, people are marking the arms, we probably wouldn't see so many mistakes. So I think it's just a little bit of a pointer there. You know, if you think, we all fall into habits and think, you know, I'm perfect at it, but actually just refresh yourself. Not everybody has the ruler, the measuring device, but a lot of the dressing packs actually come with a paper ruler. So you can just use that to double check. Just about marking the arm as well. If you're using a pen, you know, just make sure it's water soluble, because we don't want the local or the applicator going through the ink and causing any inadvertent tattooing. Measuring the implant after removal. This is only come about within the last couple of years, because we've seen people who haven't realised that when they've had their removal, there's been a little bit left in because it's been a broken implant, and that little bit that's been left in is still sufficient enough to prevent ovulation, and then people have wanted to get pregnant and haven't been able to. So I think it's really crucial. We used to say if you had a tricky removal, measure it, but in actual fact, it's worth doing on everybody. Just double check. So if you've got the paper measuring device, as you saw in the video, just pop your little implant on there and double check it's 4 centimeters. If you're not using them, normally on the blue handled blade, your scalpel, if you look very closely, so the little measure on there, there's the ruler, so just place it on there and double check. If you're one of the unlucky practitioners and when you do remove it, it's not all there, by all means have a little look at the other end, see if you can remove it from the proximal tip. If that's doable, that's absolutely fine. It will mean another incision. But if it's non-palpable and you don't know where it is, it's a case of just keeping the bit that you've retrieved and refer the patient onto your expert removal for perhaps some scanning or x-ray to see where the other little bit has moved to. Equipment, so I think it's basic equipment that everybody should have in general practice areas and in sexual health. Basic dressing pack, and I think some of the sort of objections to this is the cost sometimes associated with fitting an implant. And what we've noticed recently is some areas are buying in the specific equipment, which is an insertion pack or removal pack. And yeah, it sounds common sense. Why wouldn't you just buy the pack that's for that particular procedure? When you open the pack, when you look inside, there's lots of plastic, there's lots of instruments, lots of paper, lots of things that we don't actually even use. So basic dressing pack, and then add in your syringes, add in your stereo strips, and then you'll find that there's no waste there. So I think just have a look at what you're using, and you know, is there anything you can do to make it a little bit more cheaper, and obviously thinking about the environment as well. Single person procedure, the only recommendation for doing an implant is this, there has to be somebody else in the building, in the vicinity, that has BLS and anaphylaxis training on board, because if in the event of a vasovagal or an emergency, you need somebody else there. You don't actually have to have an assistant. It's nice if you've got one. I think it's a luxury these days to have that extra body that can come in and help, because it's nice that they can, you know, speak to someone that's potentially a little bit anxious, but generally we would just fit or remove on our own. We don't need an assistant. Self-harming, so this is just something as a team that we identified several years ago. If somebody's cutting, so the self-harming and the cutting, potentially they may disrupt or dislodge their implant when they're in the zone of cutting. It's not intentional, it's just something that happens. So what we recommended is, if you identify somebody's self-harmer, when you're rolling the sleeves up and you notice fresh cuts or historical cuts, have that conversation with the patient. And if it seems that it might be more beneficial, fit their implant in their dominant arm. And it might just mean that when they are cutting, they can't access their implant as easily. So it's just something to consider. But in the majority of people, we would always still recommend implant fit in their non-dominant arm. Drug interactions, I've already alluded a little bit to this, so it's looking at the likes of your St. John's wort, modafinil, topiramate, and I think obviously, you know, we can see it on the screen, as I've already mentioned, but people do share medication with friends, and I think people get things from elsewhere that we don't know about. So just make a point of asking, is there anything in particular, any of the medication that you're on that we can't see on your screen here within your medical records? It may be that they're buying a modafinil off the internet, and that's the narcolepsy medication. You tend to find that's quite popular in some of the student areas. They buy it off the internet. It's a stimulant. It keeps them awake because obviously as a student, they want to, you know, work hard and play hard. And that particular medication enables them to do that. But what they don't know is it's an enzyme inducer, and it potentially will stop the implant from working, and then potentially cause bleeding as well. So just ask the questions and double check that there's nothing significant. Ensure the implant is available in pharmacy or within practice. So everywhere's slightly different as to how they manage this. And I think it's just about having a mechanism in place where if you do get somebody coming in who is maybe opportunistic, fit, eligible, had one previously and would love one today, but you don't have one in stock or you don't have one at the local pharmacy, it's a shame that that lady then gets denied her method of choice. And I think we've waited 2 years now to try and get on top of these backlogs of people waiting for LARCs. It's such a shame if somebody accesses and we can't fit it there and then. So I don't know how you manage it within your areas, but I think it's just useful to have that conversation. If you've got your pharmacy on board and they know to stock more. So for example, somebody the other day I've trained to fit in a hospital. I fitted 6 in one day, and then the next day she had a few more booked in. But the pharmacy, because they weren't aware of this new demand for fits of implants, they didn't have any stocks. So she wasn't able to fit implants on those ladies that day, which post-delivery, it's such a shame that she wasn't able to do it. So it's just making sure you've got that availability. Templates and documentation. I'm guessing you're all very familiar with System 1 or EMIS, and you've got the Ardens templates in there, because I think there is a lot to cover when you are counselling for contraception, and also when you're doing the procedure. And it is just really important to capture everything that you're doing. So some of the newer things that we're making sure of is that we make sure that the 4 centimetres has been documented. So you've retrieved your full 4 centimetres, so we know it's completely out, it's in its entirety. If you're repositioning it, because that's what we're still finding, some of the implants that we're seeing historically have been fitted a little bit higher up, more towards the bicep. So we're reciting them to be in line with the guidance. So it's just worth documenting that, just so it's the form of communication as well for any colleagues that may not be aware of these changes. But I think it is just vital that we have everything captured. You know, even things like, you know, the bruising and the swelling. Some people do come back and complain about the bruising and swelling. It isn't always evident the minute we do the procedure, but they may 2 or 3 days later present with some, you know, quite serious bruising, which is fine, but it might not be, you know, they might be a bit disappointed because they may be going to prom, getting married, and it affects the clothing that they're wearing. I know that sounds quite trivial, but I think you want to just avoid complaints at all costs, really. Missed opportunity. So this is maybe the ladies that access for emergency contraception because they're not great at taking their pills, or they can't get in on time for their depot injection. So all the reasons why, you know, people are getting pregnant unnecessarily, you know, look at what we can do. And if it's somebody that's, you know, pill taker, or they're just hectic, is it worth having that conversation about the LARC? And again, you know, historically, we would say post-delivery of a baby, oh, you don't need to worry about contraception. You know, it's weeks before you can ovulate again. But in actual fact, it's very soon after delivery. So, you know, if you're seeing people postnatally, or prenatal, even before they have their babies, make sure they're aware that contraception really needs to be on board at day 21. That's the optimum. It can be commenced before day 21, off license, of course. But if you've got highly vulnerable people and you think, you know, I've got them here, this is the right time to do it, we want to prevent that next TOP or that next unplanned pregnancy, just make sure you have those conversations. UK MEC. So we know UK MEC is 2016. The faculty will always update if there's any changes on there. And I think what you have to remember is it's a progestogen. There aren't many reasons why somebody couldn't have a progestogen. There aren't many 3s and 4s associated with this particular method. But something that we are seeing a lot more of now is women who've had great success with their method, this particular method, and the whole purpose of it is fit and forget. So we don't see them for 3 years, but what might happen in that 3 years can be quite significant. So if anything changes medically or with medication, it may change their UK-MEC score. So if we don't see them, they may be, walking around with an implant in, and they've all of a sudden become a UK-MEC 3, which isn't really the ideal. So now anybody that I fit an implant on, as I give them their user card, I just say, if anything changes within your medical history, anything family-wise, or there's just something that's changed, new medication, it is worth just checking in just to double check that isn't going to change your eligibility for this particular method. Adverse event reporting, so hopefully we don't see too many of these, but this is things like skin reaction, post-insertion, any failed devices, anybody that gets pregnant while the implant is in situ. We know it's a very effective method, but we still see failed implants, so it's good to know why. Is it a true failure? Is it because maybe they were pregnant when it went in and we didn't know? Is it use of enzyme inducers that has caused it? So anything like that needs to be reported via the yellow card scheme, and you can see the link there. Just report it as soon as you can. The difficulty often can be you haven't fitted that device in the first instance. It's somebody that's maybe come from another practice, and you don't have information about who fitted it, where it was fitted, batch numbers, etc. The yellow card scheme will push for that information. I think it's just a case of saying, all I can say is it's been fitted and this is the result. This is the negative result I'm reporting. If you haven't got the other information, it's just that's the end of it. You can't really tell them anymore. But don't let that put you off, because I think that is the problem. It's so difficult sometimes to particularly, flag up these problems. It does put people off, and I think maybe don't capture as much as we need to in relation to adverse events. That's just the training and revalidation sort of process. So the OTA is the online theory assessment. I think a lot of you on here today have probably previously sat the EKA, which was the electronic knowledge assessment. So the OTA is just the new and updated version of that. So anybody wanting to do implants from new has to sit the online theory assessment, or anybody wanting to convert from a local letter to a faculty letter has to do the OTA as well. We do have a team of nurses that can do revision sessions to prepare people for the exam, because it is £75 per attempt, and I think it just put people off. So if the support there, it does tend to help our HCPs get through the exam a little bit quicker. Module 14 is the implant module. It used to be module 17, but when all the diploma was updated and sort of revamped, they changed it to number 14. We can always come in and do model arm training if people feel that they haven't done enough procedures and they need a little bit of support, or if it's time for revalidation and they don't meet the criteria for that recertification for their lock. We can come in and do a full session of ins and outs just to make sure they get their numbers up, so when they do submit the paperwork, they've passed all the criteria there. Any questions? I've stunned everybody. Any questions, Michelle?
There's no more questions in the chat. I don't know if anybody wants to unmute and ask any. Well, what are the numbers needed for recertification?
So it's really strange. So you could do nothing for 4 years, and in the last year, that's the only evidence they want to see. So in that last year of before you're due to recertify, as long as you've done 6, that's all you need to do. And one of them has to be a removal. If you've done more removals, that's fine. And they don't ask, obviously they can't ask for specifics, so you literally have to document the date that you did it, and I think the clinic where you did it. But other than that, for obvious reasons, you can't share personal data. So they're very much, looking at trusting, what you're saying. But yeah, it's not an awful lot. But I think if you're not doing any at all in a year, it begs the question, is there a need for you to be doing it in your practice? For obvious reasons, we had 2 years of not doing very many at all. So that's what we're going in and doing the support sessions for. But I think, if it's good to do a couple of months of ins and outs just to keep your skills up.
When making the incision to remove the implant, do you put the blade in at 90 degrees to the skin?
So when I'm doing the blade 11 for the removal goes in, literally, it's hard to demonstrate actually on here, and I haven't got a blade. So I don't know if you saw in the video, so it's very much, I'm trying to think of the angle really that you're going at. So it's more, I don't know if can you see what I'm doing, Michelle, or not? I'm not sure if people can see it. No, it's more, so you're going in, I think was it on the video? We used to do a pop in the skin. We used to go straight down and do a pop in the skin to try and release the capsule very quickly. But that was identified with some women, if they're very slight, very thin, you might actually end up going too deep. So I think all I can say it's hard to demonstrate is maybe to watch module 14, watch the videos again, which are on at module 14.
Do you want me to put, hang on, we're making an incision to remove the implant 90 degrees. Do you want me to have a quick check on the video and see what it says on the video, or do you want me to show the video again?
Do you want to show the video again? Is that all right? Just get to that point.
Yep, so I need to.
Was there any other questions, Michelle, while you're doing that?
Thanks, just wanted to know if we go straight down into the skin or not.
We used to do that, but now it's more of an angle, and you'll see the angle on the video, and that's just because, and I think it depends on what blade you're using as well. We very much like blade 11 for training. It's nice and pointy, and it means you can make a very quick incision. And because it's pointy, you get in very quickly. The blade 15 is very rounded and blunt, and what we're finding with that is you have to put a lot of pressure behind it, and then all of a sudden you're in and you've made too big an incision, so potentially there's more bleeding and a bigger wound than is necessary. So now we go in more of an angle, and I'm sure on the video you can see Pam doing that.
Now, shall I put the video on and show the removal one more time?
Can you sort of fast forward to that little bit dead quick?
Yeah, I'm just going to quickly share.
Thanks,
now.
Michelle.
Give me 1 second.
Thank you.
Apologies for the picture of the dog, but I need to see his little face every day. Right. So removal, give me 1 second. Let me see if I can find the video for you. And I can just try and skim it along to where we need it. Sorry, I'm just trying to fast forward it without missing anything.
Thank you, Michelle. Can you manage, Michelle? This is where face-to-face meetings are so much easier.
Well, I'll just quickly stop. Do you want me just to leave it there?
It's not playing, Michelle.
Well, I've just paused it.
All right, I can't see anything.
Can you see now?
The implant should pop out of the incision.
Can you just go back
The implant can now be removed. If it does not pop out, of 2 millimeters towards the elbow. Take care not to cut the tip of the implant. The tip of the implant should pop out of the incision. The implant can now be removed.
I hope that's
if it does not pop out, gently push the implant.
Yeah.
I hope that answers your question. But again, more than happy to come to wherever the practice is and do a quick demo if that would help.
Like I say, we'll plan these virtually just because virtual seems to be fitting into people's capacity. And
yeah,
but I think, you know, if there's a need and people would feel happier, because there's a nice networking thing about having a fitter forum and having everybody together, because you can all share your best practice and talk about challenges and things. So if you think that having a face-to-face, we can book a hotel on an evening, on a lunchtime, whatever really suits the healthcare professionals in the area, and we can do a face-to-face and just try it. It's just more find out what's the best time for yourselves. Is it during the day? Is it on an evening? and then we can just get somewhere central to Sheffield if that's easiest.
Any other questions while we're on?
Hasn't any more come up in the chat? I have put some links just into some resources, and I've put Sarah's and my email address in the chat as well. Just if, oh, hang on, there's a message just come in. No, there are no questions.
Oh, okay.
Thank you. Just you've got our contact details in case maybe something springs to mind after the meeting. I think you arranged, don't you, for the certificates and everything, Sarah, is that right? Once I get the list.
As long as I get the attendance list, Michelle, it'll be next week when I send the certificates out. But yeah, that'll make sure that gets done, no problem.
But if nobody has any more questions, but like I say, Sarah and my email addresses in the chat, also with like links to certain resources. If you think of anything after the meeting, please just email either one of us, and we'll do whatever we can to answer whatever questions you might have. Is that okay? Thank you so much for your time today, everybody.
Thanks. It's nice to see everyone. Thank you. And thanks, Michelle. See you later.
No problem.
Bye.
Take care, everyone.
Bye. Bye.
Bye. Bye.